want to introduce our guest today. Her name is Kalika Campbell. As I mentioned, she is from Theta Care. Welcome, Kalika. Thank you so much for being here. All right, so our first question that we always start off with is, tell us a little bit about your background, how you got to be where you are as far as your education, if you worked for any other employers or in any other departments, and really what it took to get you to where you are today.
Sure. So I actually knew I wanted to go into healthcare early. My two youngest siblings were both in the NICU for extended stays. They were between 6 and 8 weeks early. We had some experience in NICU when I was young, and I just knew based on those conversations with those nurses and watching them care for them that that's what I wanted to do. Now, clearly I'm not in NICU, so I didn't end up completely going that direction. So I started early. In high school, I actually took my CNA course right before my senior year of high school. So I worked in an assisted living home for 4 years, actually. I worked my senior year of high school as a CNA and then just continued there. Once I went to school, I actually took a year off in between high school and college. I graduated a little young, so just took some time to make some money and head back to school. I went to Marian University in Fond du Lac. My reason I went there was simply because they're a private school and they had smaller class sizes, which I really felt was beneficial for learning. So I continued to work at the assisted living during that time. Once I got through about sophomore year, I decided that I would like some hospital experience versus just assisted living. And so then I started my career with Theta Care. So I have actually been with Theta Care for 9 years now. I started on their medical services floor as a nursing assistant, which was actually really nice when I started because we had the capacity to do extra skills that they've now taken away from nursing assistants. So I got to do Foley insertions for catheters. I got to start to do EKGs. There was just some extra things that I got to do and gain experience with. Once I graduated nursing school, I actually continued my career on the medical services floor initially, even though I knew I wanted to go to either labor and delivery or NICU eventually. And the reason that I did that was I wanted to have the medical experience and the medical skill background before I went to a specialty unit. I worked there for about 2.5 years and then decided that that was long enough to get my base experience. I had been on that floor about 5 years. And so I decided to see about labor and delivery. I had considered NICU at the same time too. However, with working for Theta Care, I would have actually had to leave Theta Care to work in the NICU. Even though it's in the same hospital, they're different hospitals technically. So I chose labor and delivery, and honestly, that was the best decision because it's the best of both worlds. I can take care of babies, but I also get to take care of my adult patients still. So about 2 years into that, they asked me if I'd be willing to be a charge nurse. So now I still do labor and delivery, but I do charge nurse and occasionally will still take patients on the floor.
That is wonderful. You've had a lot of great experiences already in your career. I think now we've been hearing these phrases a few times over the sessions that we've had. So I'm going to ask you to dive into a couple of them. So med services, can you tell us more of what that entails, what types of patients you would see, and kind of what your day-to-day looked like when you were there?
Sure. So the medical unit is really, at least mine, was almost a glorified nursing home with more acute care. So when you think of medical services, it's really all of those patients that are coming in for pneumonia, congestive heart failure. It could be a really bad case of influenza. Obviously now that includes COVID, but really it's your patients that are sick enough that they need help in the hospital. So they need IV antibiotics, they might need breathing help. And really a day-to-day with them is you would come in, you take, I honestly don't know how many patients that they take currently, but when I did it, it was about 6. So you take 6 patients, you would do your morning assessments, you would do your meds for them, help them eat, help them bathe, really just taking care of them, but you're adding in the extra services like taking care of their IV, giving them IV medication. You might have them on telemetry, so you might be watching what their heart is doing and reacting appropriately to that. I guess I'm not sure what else you'd like to know about that.
No, that's always helpful to understand like what you might be experiencing. So it sounds like you had an older population of people, and then they would be, is that considered inpatient because they might be there for a few days or weeks or however long it might take?
Correct. So it was mostly inpatient. I will say the unit that I worked on was also our outpatient cardiac unit as well. So we would get the day stays that came up from a cardiac procedure that we were just monitoring for a few hours afterwards, or we would get all the chest pain that wouldn't technically be an inpatient. So if we were watching them for chest pain and drawing serial troponin and just watching their lab work in a telemetry monitor, then technically they would be observation and only would be about a day, 24-hour stay. But the
Okay.
majority of the patients were year long term. I mean, there were some that were there for months while we were waiting for nursing home placement for them.
Oh, wow, sure. So Skylar already had a question because it sounds like you kind of worked with, a whole range of ages. Skylar wants to know, do you have specific types of patients you prefer to work with? So maybe like, what is your favorite type of patient to work with now that you've done a few different departments?
So if we're talking what kind of patients I like to work with when I worked on the medical floor, my favorite was the cardiac day stay patients. I loved talking to the cardiologists and I loved the wealth of knowledge that they had. So I really enjoyed taking care of them. It also doesn't hurt that they were technically easier to take care of because usually they were pretty well able to take care of themselves, but were just being monitored for chest pain. Obviously, if we're talking over the course of time, all the patients that I've ever cared for, well, then my answer will be my labor and delivery patients are my favorite.
Excellent. Let's talk a little bit more about that. So one question that had actually come in ahead of time, and you kind of touched on this. A student asked, as a labor delivery nurse, do you get to work in the NICU too? So it sounds like that's a completely different thing. Did you just kind of make the choice or did you need to get additional training to be in NICU? What was part of the decision-making process? I know you mentioned the separate hospital, so that was kind of the decider.
Sure. So for me personally, the decision was really that it was a separate hospital, and I had seniority in my hospital, so I wasn't quite willing to take the total transfer and start as a baby in a new hospital, basically. But really, we work very closely with the NICU, at least on my labor and delivery unit. They are literally down the hall from us. It's a separate hospital, but they're literally down the hall. So we work very closely with the NICU nurses. We'll take our moms over there, our NICU moms. We'll take them over to visit their babies, or we'll bring milk over for the moms. But we don't actually physically work in the NICU at all.
Got it. So that kind of takes us back to where you're at now. And we had several students wondering ahead of time, what do labor and delivery nurses do on a daily basis?
So I guess it honestly depends what type of a hospital you work for. There are some hospitals that have separate, I guess, sections of the hospital for which patients you're caring for. So we kind of label them in a couple different ways. So there's antepartum, which means that they're still pregnant. There's something complicating their pregnancy, and so they're going to be staying in the hospital with us long term. Depending on the patient, we'll be doing a certain amount of monitoring of baby and contractions, giving them their medicines, and really just monitoring them, and they're in the hospital in case something serious happens. So we have those patients who tend to be a little bit more like a medical patient. And then we also obviously will take care of labors. So either labor induction, that they have something going on with their pregnancy that they need to deliver now, or they just come in spontaneous labor. So you can take care of them. And then recovery. So usually there's really no difference in nurses who can take care of a labor and who can take care of a recovery, because recovery is just that they've delivered and now you're watching them closely for 2 hours. And then postpartum, and that's just the mother-baby couplet afterwards and taking care of them. You also have C-sections, so you can prep a C-section for surgery and then recover them and then postpartum. And we also have nurses who will then circulate, like you think of an OR nurse, they will circulate that C-section. And then you have your charge nurse who kind of maintains the flow of the floor, helps with all the emergencies, resources, all of the new nurses. So you can have those areas all separated at some hospitals. However, the one I work at, all of our nurses are trained in all of those areas. The only ones that all of our nurses are not trained in is circulating the C-section, being the OR nurse, or charge nurse. Those are more specialized, and so only a handful of our staff can do those.
All right. So students, if you have some specific questions about what that looks like, so we're understanding the type of patients that you would be working with and the fact that you're a charge nurse now. So can you dig in a little more? So it sounds like there's several charge nurses maybe within your staff, depending on who works what shift. What are some of the things that you would be doing daily as the charge nurse?
So as the charge nurse, we do like a daily huddle in the morning. So our oncoming staff has to do a surgical scrub because we can all be in the OR at some point during the day. So they do their surgical scrub. While they're doing the scrub, our charge nurses come in a half hour before the rest of the staff for the day. And we get a full rundown of what's happening with every patient in every room on the floor, as well as what's being planned to come in for the day. So then we would go into the nursery where everyone else has done their scrub, and we do a high-level overview of the floor. So we make sure everyone knows who their assignment is and what they have. If any of the patients are high risk, we do call that out during our huddle so that all the staff are aware that we have high-risk patients on the floor. And then truthfully, after that, it's just kind of checking on everyone after they've gotten their assignments, making sure that they're doing okay, that they don't have any questions. If we have newer nurses on for the day, we sit down and we'll do what we call a critical thinking tool with them, go over their patient, what to expect, what emergency situations they may come across with that patient for the day, and just make sure that everyone has what they need for the day. And then the charge nurse will then meet, and we do what's called a stat sheet. So we will meet with both the supervisor and the manager of the unit and give them a high-level overview of the floor and what high-risk patients we have. That's kind of the end of our plan today, though. So that's over by like 9 a.m. And then truthfully, it's resourcing. My day is taking phone calls from the offices, assigning patients that are coming in to nurses, texting for help if we don't have enough staff to take the patients that are coming in. I will take triage patients too, because we act as an ER for pregnant patients. They, if they're greater than 20 weeks, they come to us instead of the ER. Unless it's a serious like breathing emergency or something that's not pregnancy related at all. So I will triage patients throughout the day, help with all of any questions anyone has, help when they're struggling in their rooms with their patients until the end of the day, then we'll set up for the next shift.
Wow, that's awesome. So would you say, like, do you work with, a patient or two probably every day, even though you don't have a full caseload of patients each day? Do you at least get that contact probably daily?
Right. So I am in almost every patient room. So not typically the antepartums if they don't need help, but throughout the course of the day, I'm in at least half of the patient's room, whether it's helping someone reposition them, helping with an IV start, breaking someone for lunch. So I watch their patient and take care of them for their lunch break, triaging my own patients. If I don't have staff to take them, then I take them. So I'm in rooms all day long. It's not like I don't see a patient all day being charged.
Gotcha. That really helps me understand. And Chelsea had asked a question, what are the extra qualifications or certifications you need to be a charge nurse?
So technically there aren't any qualifications or certifications that you have to be a charge nurse. Really, it was just a few short days of training for it. The only qualifications they usually have is experience level. So a minimum of 2 to 3 years of experience to be a charge nurse is what I would say is typically the criteria.
Excellent. Do you think there are certain skills that help you be ready for that position or be good at your job? Can you think of some skills that you would look for in a nurse to become a charge nurse?
So a charge nurse, really truthfully, you can't be rattled easily. You are the person that's going to be called whenever something is going wrong. And so you have to be able to walk into a room and have excellent situational awareness and critical thinking skills, because everyone else is in the middle of it, and you have to be able to look at the room and see what's most important at that point. So critical thinking and situational awareness are highly necessary skills. But I would also say that you have to be able to constructively criticize as well. And what I mean by that is, as a charge nurse, you are responsible for mentoring and resourcing all of the new staff on the floor. And so you need to be able to communicate effectively with them without demeaning them if they're not acting correctly or appropriately.
Yeah, excellent, excellent. So what do you find most rewarding about your role? And then maybe what are your biggest challenges?
Sure. So I absolutely love being a charge nurse because I love resourcing and I love teaching. And so it's really fun for me to be able to come to everyone's side and to work alongside them and just help them to figure out what is going on, or to talk them through a new situation, or even truthfully, I get called to a lot of the deliveries as charge nurse, so that's also a perk as well. I get to be in more of the deliveries. Challenges though, I mean, when we're having issues, obviously not everyone works well together and there are conflicts. So that is one of the more challenging sides of my position, is that I have to be able to mediate those conflicts. I would say that conflicts between nurses are easier to mediate than conflicts between nurses and providers. So unfortunately, as the charge nurse, if there is conflict between nurses and providers, I am responsible for helping to mediate those, as well as responsible for then escalating and unfortunately going above the physician's head to management. So that's probably the most challenging part of my specific job.
Oh, yeah, definitely. Chelsea was also asking, what does a labor and delivery nurse do on a daily basis that's different than what you do as the charge nurse? So it sounds like the labor and delivery nurse probably has a much more specific focus, whereas you are kind of assessing everything and you're kind of like the utility to help out. Maybe you can dig into that labor and delivery nurse more.
As a labor nurse, depending what type of the labor you get, so you would come into your shift, you would do your scrub, you would then get report on your patient or patients. So if you have mom babies, usually you get 3 mom babies. So then you would just get report on them. You would figure out how frequently you needed to get vitals and assessments on them. And really, mom babies is a lot of nursing support, truthfully, than anything else. So it's getting their vitals, getting their assessments, helping with their breastfeeding attempts, doing, baby chores. So they get to do hearing screens, they get to do labs on babies or blood sugars, car seat studies where they'll put EKG patches and pulse ox on, and they will make sure a baby doesn't have any heart rate or breathing issues while in a car seat. So that's kind of the gist of a mom baby, high level anyway. So if you come in and you have a labor though, from a start of an induction, you would do all of their admission paperwork with them. You would get an assessment in, get vitals in, and then obviously we're always monitoring baby as well and contractions for that. So you'd put all that equipment on. And then really it's supporting them through their day. So if it's an induction, typically we'd be starting Pitocin, and you would increase that every 15 minutes if it's appropriate. And then once they start to get uncomfortable, that's when you're kind of in the room all of the time. So if they're getting uncomfortable, it's really based on patient wishes. Some patients want to do everything with no pain meds whatsoever, and so they need a lot of hands-on labor support. They need their nurse to be at their bedside, and they need them to be helping with position changes, showing them what they can do. Do they need to sit on the labor ball? Do they need to squat? Do they need to get in the tub for pain control? If the patient wants more than that, then we can help them through, they can do nitrous oxide for pain relief. We can give them IV pain medication for pain relief. We can be the assistant during the epidural for the anesthesiologist if they'd like an epidural. And once your patient gets an epidural, then it's frequent position changes every 20 to 30 minutes just to make sure that labor is still progressing. Cervical checks when warranted. We actually try not to do them too frequently unless the mom is feeling something different or the baby's heart rate is showing changes that we need to assess what's happening. And then that nurse will be with that patient if they deliver on their shift anyway. Then we'll prep for delivery. So set up the warmer for baby, set up the table with instruments for the doctor to have, and then they will coach that patient through pushing, coach them through delivery. The doctor, obviously, usually the doctor delivers once in a while. They can't get there in time, and so one of the nurses will deliver. And then recovery, then they'll do recovery after delivery. So they'll do fundal checks. So they'll check how mom's uterus feels every 15 minutes for 2 hours and do vitals at the same time. and just help make sure they'll check baby every half hour for vitals and help mom with beats. And then they roll into a mom baby. So I don't know if that helps a little bit with kind of what a day-to-day would look like if you actually have a labor patient.
Yeah, I think so. So it sounds like, so you either have kind of one group or the other. Is that right?
Yeah, so
Okay.
you wouldn't have a labor and mom babies. If you have a labor, it's a one-to-one assignment. So it has to be one nurse per one labor. If you have mom babies, it's a 1-to-6. So you can have one nurse to 3 mom baby couplets. If you have a C-section, it's the same thing. It's one nurse to one C-section patient. And if you have antepartums, depending on their stability, so if they're not stable and we think they might just deliver on us, then it's 1-to-1. If they're stable, you can have up to 3 antepartum patients.
I see. That's really interesting. How many rooms or patients do you have in your department?
So we have 16 labor rooms and we have 16 antepartum rooms.
Okay.
So the antepartum rooms can be dual purpose though. So if our labor rooms are full, we will move our postpartum patients to the antepartum rooms so that we have labor rooms available for our laboring patients.
Sure, sure. And what shifts do you work in your department? Are they 212s? How does that look?
So at my hospital, everyone is required to work rotating shifts. So everyone's required to work about 3 weeks of nights and 3 weeks of days in every 6-week rotation. And we all work 12-hour shifts. So it's either 6 a.m. to 6:30 p.m. or 6 p.m. to 6:30 a.m. And then depending on your FTE, it'll depend how many shifts you work. So like I'm a 0.75, so I work 2 shifts 1 week and 3 another. But if you were a full-time, if you were a 0.9, you'd work 3 and 3.
Wow, that's interesting. All right, we have a few more questions coming in. Skylar wants to know, and this is a good question, would the same person perform a delivery as would that same person do a C-section?
Yeah, so that's what's really unique and nice about the hospital that I work at is that all of us are we're all trained to every portion. So I could come in and I could have a labor. I could come in and I could have a C-section prep planned. I could come in and I could circulate. I could come in and I could have those antepartum patients. I could come in and I could have mom babies. I mean, typically I obviously come in and do charge, but you can also, the same nurse. So if I had a labor that all of a sudden her heart tones dropped and wouldn't come back up for baby, or she just wasn't progressing and we had to go to a C-section, that same nurse will then prep that patient for the C-section and go to the OR with her. They won't change nurses just because she's going from a labor to a C-section.
Sure. And then the provider would be the one that actually performs the C-section. Most of the time, do they do the delivery? Is it usually a provider?
Yeah, it's legally supposed to be a provider. So the provider would be the one to be doing the delivery or the C-section. The only time it's not is if you have a patient just come in and all of a sudden they're delivering a baby before we can get a doctor there.
Sure, sure. Excellent. All right, Chelsea's wondering, what does the room look like in a normal delivery? How many staff would there be? So nurses, doctors, et cetera. How many people would be in the room maybe during the labor and delivery?
So during labor, if it's a normal labor, you would just have the one nurse with your patient. You might call in a second nurse if you need help, like holding a leg for pushing. And then for delivery, you should have your provider there, your obstetric provider there. You should have your labor nurse, and then you should have at least one nurse as a baby nurse. Typically, honestly, there's usually 2 nurses that will come for the first 5 minutes just to make sure that baby's okay. So you'd have 3 nurses in the room and 1 provider. If we had any indications that the baby might not be perfectly fine at delivery, that we might need to do some interventions, then we would also have the pediatrician at delivery as well.
Sure. Oh, excellent. Excellent. All right, students, we are going to be wrapping up here pretty soon, but before we do, I would love to touch a little bit more on kind of the education side of things. And you gave us really great details about why you chose the school that you did. I'm just looking over some of the questions. Like, what classes do you recommend taking, and how difficult was it to get into, nursing school and then get your RN?
As far as classes, a lot of math and science-based classes in high school are your friend. They'll prepare you for those math and science classes in nursing school. As far as how hard it is to go to nursing school, it honestly depends on how you are as a student. I mean, it's going to be challenging. It takes a lot of hard work and dedication, and there's a lot of hours involved. So I guess I don't really have a good answer to that. It's challenging, but it's honestly rewarding. You do all that work to prepare for the NCLEX, and honestly, they prepare you so well. It's terrifying to have to take it, but a lot of people, I mean, there's very few people that actually fail it. You've been prepared very well, and they work really hard in school to make sure that you're ready for it.
Excellent, excellent. All right, Kiera has a good maybe wrap-up question here. What was the hardest delivery you've helped with, if you're able to share some of those details with us?
So that's a good question. And to be honest with you, I don't think you guys actually want the answer to that one. So the hard part about labor and delivery is that it is 95 to 99% good, right? But we also know that it's partially bad. So the hardest deliveries that I have ever had to help with honestly didn't have good outcomes. And it was nothing that the labor staff did. It was nothing that the parents did. It's just unfortunately that sometimes things happen. So my scope of hardest deliveries would be the stillbirths that we've had. And I don't really know that it'd be appropriate to go into details of those,
Certainly.
Unfortunately.
Yeah, you gave, that's a really great answer. And I guess what that makes me wonder next is, how were you prepared for outcomes like that? Was there anything specific, maybe early on in your training, that happened that helped you prepare for that possible outcome?
During training, we always knew that that's a possibility. I would say that you're never fully prepared until it happens to you. So it's something that I think all of our nurses process the most the first time that they actually have to care for a patient that has that outcome.
Yeah, certainly. Certainly. Well, maybe let's end on a more upbeat note. If you had any advice for students who are thinking about going into this department or this area, what would that be?
Honestly, I really, and it's partially because I did it myself, but I really think that it's beneficial. One, if you could do an OB clinical rotation in your nursing school, that's going to be highly beneficial. So you can even just see what it's like on a day-to-day. And then do a job shadow. They're available. Even now, they are starting to become available again. So I would really recommend an OB clinical and then also a job shadow. And then I would recommend trying to start on a general medical floor. I think there's a lot to be said about honing in your skills before you go to a specialty unit. And labor and delivery is unique because you're caring for two patients at one time. So even though mom might be okay, we might be having to watch for something on baby. And even if baby's okay, it might be mom. So you're caring for two in one. So it's really nice to get experience caring for just one patient at a time on a medical floor beforehand, I think. Now, I will say that we do have nurses who have started just solely on labor and delivery, and they do well too. But I do think that there's something to be said about that experience.
Yeah, excellent. Excellent. Well, that is wonderful advice. Kalika, we really appreciate you sharing your expertise and your experience in this really unique area. Kalika, thank you very much for your time. And everyone, thanks for joining us today. Have a great day.
All right. Thank you.
Thank you.